Well, good evening, ladies and gentlemen. Thank you for coming out to the Da Vinci Science Center tonight. My name is Dennis Zahner. I'm the Manager of Marketing and Communications for the Da Vinci Science Center, and we're welcoming you to our Public Fact Forum program on the Ebola virus. Interestingly enough about the Da Vinci Science Center, as we know, every day young people are engaged and they have a lot of fun exploring science and technology here every day, and we're very proud to be known primarily for that. But we also believe, at the same time, it's our responsibility to be a community leader and an advocate for good, high-quality information. That's why we do fact forum programs like these, and we've done them before over the years, whenever there's a significant national or international event that is based in science and technology. As we know, every day information is more and more plentiful as we go, but sometimes that information, or a glut of information, is not always clear or balanced or unbiased. So at the Da Vinci Science Center, what we say is we're not about the quantity of information, it's about the quality of information, or as one of our friends put it on Facebook this past weekend, facts over fear. And that's what we espouse at the Da Vinci Science Center. We have three great panelists with us, and we couldn't do programs like these without our great partners, so I'm going to introduce them shortly. From the St. Luke's University Health Network, we have Dr. Peter Ender, a physician in the Infectious Diseases and Internal Medicine Division. Thank you, Dr. Ender, for joining us. From the Pennsylvania, and this is a tongue twister, so Pennsylvania Hospital and Healthsystem Association, say that 3 times fast. We have Dr. Tom Grace, who is the Vice President for Emergency Preparedness. Welcome. And from Lehigh Valley Health Network, we have Terry Berter. If those of you who listen to WAEB or B104 radio this morning probably heard her interview, so thank you very much for that. She is the network's Director of Infection Control and Prevention. So thank you all very, very much for joining us this evening. So how we're going to work this, if you've never been to one of these before, our panelists are going to make short presentations about a component of the topic at hand, of which of course is the Ebola virus. After that, we're going to open the floor for questions, and we may even have a special guest presenter later on at the end of the evening. I'm going to be in the audience with a handheld mic to assist you when we get to the Q&A period. If you also have a smartphone and you're so inclined, you can tweet a question to us at Da Vinci Science or use the hashtag EbolaFacts. So that'll be a lot of fun. So at this time, I want to get the program started, and it's time to introduce our moderator. I said earlier this evening, he's kind of the scientific heart and soul of Da Vinci Science Center, and I do believe it. He is our Senior Director and Chief Scientist, Dr. David Smith.
Thank you, Dennis, and welcome everyone to the Da Vinci Science Center. As Dennis said, we really strive to make sure that the Science Center is a place that people can trust for information and also that can respond in timely ways. And so I also want to thank our panelists for joining us on short notice. It's often hard to get doctors able to find a little time in their schedule, and so we're very grateful that they're with us tonight. As Dennis said, we'll have some brief remarks from each panelist, and then we will have time for questions. So without further ado, we're going to start with Dr. Ender, who will be talking about the Ebola virus itself and some of the history of the virus. So I'll turn it over to Dr. Ender.
Well, I want to thank the group here who invited me for this discussion, an important topic. Let me give you some background about what my background is, give you some information so you can see where I'm coming from. I am not an Ebola virus expert. There are very few Ebola virus experts in this country. I'm a clinical infectious disease physician, and I do have some background in the military that allowed me to have additional tropical medical experience, additional training in this area with some of the viral hemorrhagic fevers, and I've also done some travel to various underdeveloped countries, including Sierra Leone in the past. So I do have a little bit more of a flavor for what some of the issues are overseas. But let me at least give you this is more of a summary that I'm going to offer you so that we can introduce the topic a little bit, and that will lead to additional topics being discussed and then the Q&A session. Okay, so Ebola virus disease is caused by, of course, the Ebola virus. It's the most lethal of the hemorrhagic fever viruses. So this isn't the only one. Matter of fact, in Sierra Leone, when I was there was another one that was more prevalent called Lassa fever. And there are other ones, such as Congo Crimean hemorrhagic fever, and that's just to name a few, most of which have been found in Africa, but in other parts of the world also. There have been, as far as Ebola, there have been many small outbreaks in the past, most of which have been in Africa. Just to give you an idea of some of the bigger outbreaks in the past have been into the several hundred cases range. So I think the biggest one was in Uganda before this current outbreak with 425 individuals. That, of course, is the ones that were confirmed. There are a lot of patients that don't get diagnosed for a variety of reasons that we may talk about later. So as far as where the reservoir of this virus is, or the source of initial infection, kind of where did it come from? It's unproven, but there's a lot of data that now suggests that the fruit bats in the area were the initial nidus of that infection, getting into the human population eventually. Past outbreaks have been in very remote areas, and they've been relatively quickly contained, certainly compared to this outbreak. And that's one of the reasons they've been contained, is that they're in those remote areas, allowing for, if you're in a very populated area, there tends to be more transmission that can occur. You've probably seen this picture on the newscasts everywhere, but this is the virus that we're going to be talking about. This is an electron microscopy image of the virus, the Ebola virus. So this gives you an idea of where the outbreaks have been in the past. So in Central Africa, a lot of these outbreaks have occurred in the past, whereas now the current outbreak is in Western Africa. There was also a small outbreak in South Africa. So let's talk about the disease process, go into some clinical information. 50 to 90% will die once they're infected with this virus. Now, that's in underdeveloped countries. My guess is that if you get high-level care at a medical center, those numbers would be much less if you get aggressive supportive care. But in the current outbreak, it's about 70%, so it falls in that range. Spread is via direct contact with blood or body fluids of infected individuals or contaminated objects. So this is not, as opposed to things like influenza and some of the other respiratory virus, it's not spread by air, it's not spread by water or food, but it is extremely contagious with contact because of the high level of virus in the body secretions in the blood. Not spread by casual contact, another important point. So this is not the type of thing that you're walking by somebody down the street that you're gonna catch. All infections, their contagiousness, they have an inherent contagiousness, but they also depend upon the intensity and duration of the exposure. So how close was that contact to the organism, and then how long have you been in contact? And then infected people are only contagious when they become ill, another very important point. The time to infection to the illness is anywhere from the time they're infected to the time they get sick, 2 to 21 days, with the average being 8 to 10 days. Initially, the patients, when they get sick initially, tend to have a lot of, unfortunately, flu-like symptoms in that they have fever, chills, headache, muscle aches, and joint pains. Subsequently, it becomes less flu-like. Later, there's more gastrointestinal type symptoms with a lot of secretions, unfortunately, produced through nausea, vomiting, diarrhea. Abdominal pain can occur. Cough tends to be less prevalent than you see with like the flu, but they can also get swollen nodes, lymph nodes. Some people end up having a rash during the course of the illness, and then unfortunately, a certain percentage of patients start hemorrhaging, and they go into multi-organ failure. So their kidneys begin to fail, they can go into respiratory failure, and so that's where the high-level support that's often not available in underdeveloped countries, unfortunately that's not available in those areas. As far as diagnosis, from what I've heard recently, the rapid testing can now be done through the Pennsylvania Department of Health, and my understanding is once somebody is identified as a possible Ebola patient, that testing can be quickly done, And within the same day, results should be back, perhaps within several hours. And it's a blood test. So it's a blood test that's looking for the genetic pieces of the virus. It's called PCR testing. And then confirmatory testing is done through the CDC. The test can be negative when the initial symptoms are present, but it always becomes positive within 3 days or so. So initially, there may be some rare situations where somebody comes in very early with limited symptoms and they get tested, and it's possible the test initially could be negative. As far as treatment and vaccines, so prevention, the primary treatment that's available now is aggressive supportive care. And that can go a long way for these types of patients. So unfortunately, these patients become profoundly dehydrated because they lose so much fluids through vomiting and diarrhea and perhaps bleeding. And they third space fluids, in other words, the fluids kind of leak into their tissues. So just aggressive hydration of patients can go a huge way. And there was a nice discussion of this in this week's, or I think it was this week's New England Journal of Medicine, from a person that has a lot of overseas experience with dealing with Ebola. There are experimental treatments. None of them have been really tested in humans. They look promising in the lab and in animal testing. There have been now compassionate use of some of these medicines. So compassionate use would be using medications that, where there's no treatment for, no known treatment, and there's a high possibility of death, and so you use these medications that are not proven to be effective and could be harmful, but they can be obtained to try something at least. As far as experimental vaccines, right now there's ongoing testing with these vaccines. They've been through the animal studies. They're now in what we call phase 1 studies, looking at humans to make sure they're safe. And then my understanding is perhaps as early as January, there's going to be more large-scale trials in individuals in Western Africa. So let's just look at the current Ebola outbreak. So Liberia, Sierra Leone, and Guinea are the 3 countries right now where there is an ongoing outbreak situation. Nigeria, unfortunately, was declared clear after they did have some cases for a period of time. They were able to contain that outbreak. 4 cases have been diagnosed in the U.S. Now, you've heard as much as I have about those cases via the news. 1 case in Spain, Senegal, and now 1 case in Mali. These are the numbers as of the 24th of October. So you can see enormous numbers compared to what we've seen before. So this outbreak is different than any other Ebola outbreak that we've ever seen.
Okay, good evening. I'm here to talk a little bit about the overall hospital preparedness and response within Pennsylvania. Obviously, the response has been a little bit on the light side. We haven't had any cases of this, and we hope that situation doesn't change. As far as what we are doing, obviously we are working with our partners, pulling together as a hospital community, and learning everything we can from the collective experiences. As the doctor has said, so far there's been very limited cases of Ebola patients in modern healthcare facilities. So to summarize, and I was trying to make notes back here real quick to get a handle on it, we've had a doctor and a caseworker who were the first to come to America. They were transferred to the Emory Medical Center down in Atlanta. Then there was a cameraman from one of the news channels who had been down covering the Ebola outbreak and was exposed and came back and was sent to Nebraska, the Nebraska University Medical Center. Then we had the traveler, Mr. Duncan, who presented in Dallas. I think that was well covered on the news. The other, to note so far, the other first 3 people have all been cured and released from healthcare facilities. Mr. Duncan was at the Academic Medical Center in Dallas. He did die to the disease. From him and treating him, 2 nurses were exposed and contracted the disease. Both of them were then transferred to special facilities as well, one to Bethesda at the National Institutes of Health, and one to Emory down in Atlanta again. And as of this morning, we heard that the 2nd nurse was cured. So both those nurses have already been treated, cured, and released. And for those who saw the photo opportunity yesterday, the Nina fan, the first nurse, actually had a photo opportunity hugging the president. So from that perspective, that's done. And then over the, really as of last Thursday, there was the additional physician who had been a Physician Without Border physician who had traveled back to New York, had symptoms of the disease, and was admitted to Bellevue Hospital in New York. So 1, 2, 3, 4, 5, 6, 7 that we've had in modern healthcare facilities, with one of those being a fatality. And we have learned from that significantly around the level of protective equipment. We've also learned about the disease some more. From the symptoms standpoint, most of the initial presentations and those who have been successfully treated have started their care during the phase where it's primarily a fever or very limited symptoms of nausea. We can say that, for lack of I'm a nurse by background as well, so I use nursing terms sometimes, but they were dry patients, that they weren't throwing up or having diarrhea at that time. They primarily were nauseated and fever and not feeling well. So from that standpoint, they were probably the least infectious as far as presenting risk to others as they came in. They were screened and they were put into appropriate containment or isolation facilities, and no one else has really received any illness from that. Again, the first two people who were brought back from Africa directly were already in a more progressed phase. They were already having the vomiting and other things, so they were having the symptoms where they could have more easily spread the disease. But again, they were coming to some of the containment facilities, the already identified and specially trained and prepared containment facilities that is operated through this, with funding from the CDC. And now most recently, the latest doctor is also being treated at a general hospital, and so far no significant issues from that. The main lessons we've learned is, again, just being fastidious about the level of protection of our staff. The lessons, as already mentioned by the doctor, as far as the disease progresses, these people, again, are losing lots of fluid in the process of that, somewhat aggressively losing the fluids, and with that, putting the healthcare providers at pretty significant risk. So again, the meticulous and much more advanced levels of protective equipment that we've routinely had available and have been training our hospitals for since 9/11, as far as what we've called decon equipment or weapon of mass destruction equipment or whatever. Those type suits, those type of respiratory protection are already in the hospitals, available to staff, and we've had limited number of staffs trained in the emergency department areas to be able to decontaminate and treat those patients. What we've had to do in the intervening 2 weeks is extend that equipment up, train specific units if we think that they're going to be kept in that hospital. Otherwise, we focused on using that training and using that equipment in the emergency departments where the people will be primarily seen. So at this point, the philosophy that we're using as we approach these scenarios is that all hospitals need to be able to receive or have someone present to them. They have to be able to identify a potential case based on the symptoms, the case studies, and the travel history. At this point, we're lucky enough to still be able to rely on a travel history primarily, and then be able to isolate that individual to prevent any further spread, protect their staffs, and move on with informing the authorities as far as, in Pennsylvania, the State Department of Health, to get the appropriate testing done. From there, depending again on whether or not the testing shows as a positive case or a high-risk case, the patient would be then moved to one of either the federal designated 4 containment facilities where the highest levels of care and isolation are available, or they may be moved to other identified facilities that have been vetted and have the appropriate staff, training, equipment, and facilities to be able to isolate these patients and provide that advanced care. As you are aware, if you followed the case and the scenario with the doctor in Bellevue, CDC was at Bellevue and was actually vetting them or inspecting them, for lack of a better term, to evaluate their readiness to be able to receive that type of patient when it was called that the doctor was coming in. So again, they were able to work right through that and keep them there. They were comfortable with their capabilities. Here in Pennsylvania, we are one of the 6 states that are going through that vetting process. Pennsylvania today started, we have the first team arriving in Pennsylvania, and CDSC is just starting here to visit their first hospital in Pennsylvania to be able to vet them so that we can see whether they are ready and can be checking all the boxes on the checklist to confirm that they have the abilities, capabilities, and willingness to be able to treat these type of patients from an ongoing basis. But again, all facilities need to be able to receive them, identify them, isolate them, protect their staff, and be able to inform the appropriate authorities so that the testing and further decisions can be made from there. So with that, I'll wrap it up. I'm sure there'll be questions later. Terry?
Good evening. As Dr. Ender and our gentleman from HAP have already explained, they've told you what's happening from Pennsylvania and also specifically about the disease. So my job is to tell you what is happening as far as the hospitals are concerned. First and foremost, our job is to make sure that we are protecting our healthcare workers and protecting our community. That is our absolute responsibility, and also to provide safe care for our patients. Because as you well know, Ebola would not be the only situation that we would need to care for. Our doors need to remain open for heart attacks, strokes, babies being born, a number of other illnesses, especially as we roll into the flu season. So first of all, let me tell you that there has been a lot of work going on in the background that you may not necessarily see, but as they have mentioned, emergency preparedness and infection control has been part of the hospital's structure for years. I've been actually there 36 years and started out in med-surg, went to the operating room for a while, but most of my career has been in the infection control department. We also have 13 infectious disease physicians. My department supports another 15 individuals who have been working very aggressively, not only on just Ebola, on H1N1 pandemic that happened in 2009, MERS, which was the disease that we were predicting would show up from the Middle East, from SARS, which was, as you well know, an Asian situation, which we actually dealt with very successfully at our Muhlenberg campus. So emerging diseases is not something new. Emergency preparedness is not something new. This disease happens to be new for the US, not new as far as Africa is concerned. So as Dr. Ender mentioned to you, we do have a lot of intel. And the unfortunate part about learning something from other facilities, much like Texas Presbyterian, we have the privilege of learning from some mishaps that took place there. And that's very unfortunate for them. The good news is we are able to benefit and make things even safer and even better. So first and foremost, our staff has received regular updates virtually every day. There is a coordinated incident management team, which I'm sure is very similar at St. Luke's. We communicate back and forth because anything that affects our community is not hospital-centric. We need to worry, just like we did for pandemic, across the entire continuum, which includes everybody within our catchment. Signs have been posted, and if you've been to any of our facilities, and I'm sure St. Luke's is very similar, we have signs posted, very large posters when you enter our facilities, in our emergency rooms, at all of our physician practices, at all our express care. So anything that is part of our network has signs posted to help individuals self-identify to us, because it basically says, notice to our patients, if you've traveled to Western Africa, Guinea, Sierra Leone, Liberia, and the posters were printed before Nigeria was actually cleared, so it's still listed on our posters, in the past 21 days, and have these symptoms: fever, diarrhea, tiredness, weakness, muscle aches, headache, vomiting, please report to our receptionist immediately. Now, the goal there is to try and get people out of the general waiting room. We want to reduce the transmission as much as possible. And again, I don't need to repeat for you what happened in Texas. It was all over the news. But unfortunately, this step, although may have been asked and identified, was not communicated all the way up to the provider. We have some additional protection as far as that's concerned. First and foremost, not only do we have the signs, which is passive screening, we have active screening. That means everyone who's entering our emergency rooms, everyone who's being picked up by a first responder or an ambulance is being asked these questions, and it's being documented. And then that information is then shared, forwarded, used over 911 comm centers to notify hospitals, I've got a patient on the way, to notify our providers and our staff to be in full protective attire when we receive that patient. I can't speak specifically for St. Luke's, but I can tell you we've had some near misses, if you will. They are not patients that ever met the full clinical definition. They were not patients that were classified as a person under investigation, and that's the way the CDC would classify them, a PUI, and therefore we have not sent away any tests. But that doesn't mean we don't have people that travel internationally and from this area. Somewhere in the vicinity of 3,000 travelers leave the area every day. Now, they don't all come back to the Lehigh Valley, but as you know, they are traveling through the airports. They have enacted a number of safeguards at the airports, which are to test people's temperature leaving this area, test them for symptoms, and most importantly, to find out when they were there, what exactly were you doing? Were you providing direct care to one of the Ebola centers, which are, I hesitate to call them hospitals because they look nothing like what we're used to here. So recognize, and I'm going to answer this question before you ask me because it's one that comes up all the time when we give these presentations. Well, why is that happening there and why isn't it happening here? Because we are privileged to have an infrastructure here. We have people that are educated. We've got very good, strong, knowledgeable physicians. We have dedicated teams of emergency providers. We have personal protective equipment that they do not have. We have lots of blood products and materials to help resuscitate these individuals. And we have actual hospitals. We have containment units. So we have a lot of things that unfortunately Africa does not have. They also have some cultural differences that are very significant. And that is when their loved one is placed in one of these units, one of these centers, if you will, and they see they're dying, one of the things they immediately want to do is grab their loved ones and take them home. Now here, we would absolutely forbid that. And we have the Department of Health to support us and the CDC. There, they do not have that structure, and so they do retrieve their loved ones. They do take them home when, in fact, it is determined that nothing can be done to save them. They then are bleeding, they have diarrhea, they are vomiting, and they infect the entire family. So unfortunately, entire families are wiped out as a result of the disease. Again, that is not happening in this country. So although we are presenting to you a very serious illness and we are taking it extremely seriously, I want you to know that preparedness is going on that you may not witness. As they mentioned, the emergency providers are, as a matter of fact, right now my staff is working with 911 and EMS at multiple locations to make sure they understand PPE. PPE is personal protective equipment. That is what you see on television, some of which is high level and some of which is entry level. What you're seeing is high level. Those are the big Tyvek suits, the big pappers that go over the heads, the rubber boots, the double gloves, duct tape. Those are for high level treatment of a patient known to have Ebola. But there's another level of equipment that many people are being trained on. You can imagine if every patient we greeted them in a spacesuit. First of all, that would be overkill. Second of all, it would be very intimidating to a patient, very tough for our providers to get a very good history and physical, and really definitely not supported by the CDC. However, if we screen them and they answer yes to both of those questions, meaning they've traveled and they have the symptoms, they're immediately removed from our waiting area, wherever that is. A mask is put on that patient, and our staff will immediately get into Tier 1 personal protective equipment. And that is a paper gown, paper booties, 2 pairs of gloves, a hood, but not like those big ones you see on television, and it's not a plastic suit, and a mask with a face guard. So they are protected, but they can continue assessing that patient to determine, does this patient really meet that criteria? Some patients, truthfully, it's unfortunate, they're convinced they have Ebola. And they're convinced because they've watched everything on television. They've watched movies, they've read books, they've seen it in magazines, and they may have a relative that's there. So by the time they get to us and they have cold or flu symptoms, they're convinced they have Ebola. And unfortunately, it's happened more than once. So our job is to drill down, ask those questions 5 different ways, and make sure that they really do not meet the criteria. Now, Dr. Ender also mentioned about a new test. There are rapid tests available, and we are in the process of procuring those tests. Because prior to this, we did have to get the Department of Health involved and the CDC, which all takes time, and then send a very secure specimen to one of these areas, and then wait for the test. The entire time, we have a patient that we have to provide care for. But recognize that 99.9% of these individuals will either have malaria, tuberculosis, typhoid. We treat, Dr. Ender treats these types of patients all the time, but not Ebola. That's not to say the risk is 0, but the risk is very small. So here's the 3 things that I'd like you to remember, and it's what we tell our staff over and over and over. And quite frankly, in every interview I've given, it's the same 3 mantras that the CDC is saying, Department of Health and everybody. Our job, first and foremost, is to prepare to detect. So detect. The earlier we identify it, the earlier we isolate it, the decrease there is in transmission. Number 2 is prepare to protect. Our job is to protect our healthcare workers, care for that sick patient, and protect you. Those doors to our hospitals, all the hospitals, must stay open. We cannot afford for anybody's hospital to go down. There's lots of people who need our care, and our job is to contain everything. And third is prepare to respond. And that is everybody has got ID and infection control's phone number. We are the first people to be called. We are on call 24/7. In the event we get a suspect patient, we will respond immediately, and we will guide our healthcare workers what are the next safe steps. We also have a huge team of about 30 people on our emergency management team, including media, and our job is to be transparent. So if there is information, we will share it with you. But what I caution you about is getting reliable information. If you read everything that's in the newspaper and everything that's on television, truthfully, you would think we were going to be extinct from Ebola. And that's not the case. So I urge you, if you really want the absolute truth, go to one of the hospital websites. We both have lots of documents up there that will tell you really the truth. And number 2, you can go to the Department of Health website, or you can go to CDC, CentersForDiseaseControl.gov. And you will get authentic, up-to-date information, including maps that will tell you exactly how many cases have been identified, how many fatalities there have been, and what their recommendations are to protect you. Hand sanitizer, and hand sanitizer. It works. The virus is fragile and will die quickly outside of the human body. So it's cleared up and cleaned with Clorox very easily. And number 2 is protect yourself all year long from blood or body fluids of another person. Always put a barrier between you, whether you're providing care at home, whether you're visiting somebody at the hospital, whether you come upon an accident, you need a barrier in between you and blood and body fluids of another individual. And my last big pitch is please get your flu shot. I know it has nothing to do with Ebola, but hundreds of thousands of people die every year from the flu, and we have a vaccine that works and is very safe. Thank you.
Thank you very much to our panelists for a very informative set of presentations. I am hoping that we answered a lot of questions that might have been out in your minds, but I'm sure that there are more questions that might have been raised by these presentations. And so at this point, we will take some questions from the audience, and Dennis is out there with the microphone. So if you would like to ask a question of our panelists, please raise your hand and wait for the mic to reach you so that we can all hear your question.
Who would like to begin? We have one right here, ma'am.
Okay, I found this in the computer, and it says that the Ebola virus can be transferred by droplet transmission, that the sneeze or cough and those sort of, you know, the expulsion from the mouth can be on the surface of the Is that true?
So did you hear the question?
Right, so when they talk about with droplets, it's within 3 feet of an individual. If there are large droplets that get aerosolized of a body fluid, and it can be, with Ebola, unfortunately, it can be a lot of different types of body fluid, it can be contagious, okay? That's different than airborne transmission, in which small pieces remain suspended in the air for a long time, and you can kind of pick it up out of the air. So it has to be within very close contact to an individual when there's an actual event of fluid going through the air.
Who else has a question?
So you actually have to get sprayed, is that what you're saying? Grossly enough.
Ma'am, you have another question?
I'm sorry. Back in 1989, there was a form of the Ebola virus that was transformed into an airborne virus. It was strictly through monkeys. What is the possibility that this form of Ebola can be transferred into an airborne virus?
So the animal studies that you're referring to, the monkey studies that were done previously, have been replicated using different types of techniques. Unfortunately, a lot of those studies, what they showed was that those monkeys were close enough together in cages that they could have spread by droplets rather than true airborne spread. The other thing is, one of the other studies did not control for the fact that monkeys do kind of funny things sometimes with their secretions, and they would literally kind of throw their feces, and so those types of things weren't controlled for in those studies. When you look at the information that's out there with this large outbreak and every other Ebola outbreak that's been there, there has not been airborne transmission documented. So is there a chance that sometime this could happen in someday? I guess there's always a chance there could be a mutation that occurs down the road, but at this point, there's nothing to support that that's a risk right now.
And just to let our panelists know, we also have some journalists with us from the Morning Call media group, the Express Times, and CBS Philadelphia is also here. If they have questions, they also can ask them, but also one from our audience. Who else has a question? Don't be shy. Ma'am?
Yeah, my family and I are doing some traveling through the airports to the United States in the upcoming months. Any suggestions for additional precautions?
Currently, there is not a definite restriction in terms of going anywhere. I will caution you that lots of places have diseases. Any place in the Caribbean now has got chikungunya, which is a mosquito-borne illness, as well as dengue. So I think it's prudent for you, no matter where you're traveling, if you go to cdc.gov, they will give you all the travel advisories and any recommendations. But what I will tell you is hand sanitizer. Carry it in your bag, the size that you're allowed on the airplane, of course, and you can also purchase antibacterial wipes. So if you're at all concerned, I carry them, and not because I'm paranoid. I mean, I have kids, I'm more paranoid about them. I carry those and hand sanitizer every place I go. I would not advise masks. There are some people that are carrying them. I would certainly caution you if you're considering traveling to Western Africa. But other than that, there isn't really any other restrictions that I'm aware of.
Other question?
You got one up front, Dennis, but let me ask a follow-up to that, which is that there's been discussion in Congress and other places about instituting travel restrictions. Do you think that there's evidence that supports that or not at this point?
Okay, great question. It's another one that we get asked all the time. And the bottom line here is, as far as restricting travel from the endemic area, the feeling of all the professionals, and certainly the CDC, is it would be the absolute wrong thing to do. And the reason for that is we need to stop the outbreak at its source, okay? Not necessarily stopping travel, because first and foremost, we do need healthcare providers to continue to go there to assist. We also have to be able to evacuate healthcare providers in the event that they become ill. And the third most important reason is, in the event that you stop travel, anytime you put up any type of restriction, people will find a way to go around it. And our biggest concern is we know now we have lots and lots of screening at all the airports. They actually have to go through several airports to get back here. Once you put up a restriction, they will find another covert way to get here, and we will not know where they are. So that is a very grave concern for all of us.
Let me just add one other twist to this. So I totally agree with everything Terry said. However, I think there's been a steep learning curve for all of us, for the government, as far as the approach that should be taken to prevent transmission in the United States. So obviously some unexpected things happened where people, just before they got ill, thought they were fine. They went out in the environment. And so perhaps the risk of transmission may not be very high in that situation, but the risk for hysteria is high. And so because of that, I totally support a gradually escalating approach of tracking people very closely when they've been known to be in direct contact with individuals with Ebola. So, you get unfortunate situations where people, they were doing okay, and then they get on a subway, or they get on a bus, or they get on a plane. And I think the CDC has now learned, more so because of the hysteria than anything, but also to protect the public at large, we need to track people closely when they come back from those areas.
And to amplify that one, maybe I like to talk on something. As far as the CDC process for tracking, that started as of Monday. At this point, the travelers from West Africa are being directed through 5 airports, all on the East Coast at this point, including I got them written here, so JFK, Newark Liberty, Atlanta Hartsfield, Dulles in Virginia, and O'Hare in Illinois. That's where, at this point, the designated airports are. And that's also when I was talking about the states being prioritized for the ability to provide definitive treatment. Those 5 states have been the first 5. And again, like I said, Pennsylvania is the 6th because between New York and DC, actually about 70% of the people who are traveling from Africa come in with their destination into this area, into the eastern seaboard area. So again, it makes good sense for us to build that capacity here as quickly as possible where we're most likely to see it. And then the goal is to continue to identify those facilities across the country.
And we have a questioner here, sir.
Yes, I'd like to ask about the fragility of this virus. What about soap and water, 70% alcohol, Clorox, and washing machine? Are they all effective?
What What we are doing, as far as our facility is concerned, is we are absolutely encouraging people to use alcohol-based hand sanitizer and Clorox. So any type of Clorox bleach, mixed, of course, not straight, 10%, so it's 1 point Clorox, 9 points water, is what we will be using to clean any area that is impacted. We also have big tubs, which they sell in the grocery store, of Clorox wipes. And both of those have been proven to be effective. As I mentioned, it is a fragile virus in terms of living on inanimate surfaces once cleaned. Actually, in Emory, they did some very significant testing where they had the 2 patients originally who were exuding large amounts of fluid, and I mean 5 to 10 liters of fluid a day, very sick. And they found the RNA virus in every body fluid. The 2 places that they did not find it is in their dialysate, which was interesting to all of us, and the second place was on surfaces that had been cleaned, they were not able to identify it there. And they were using the Clorox and water type cleaning agents, hand sanitizer. Now your question is soap and water. Soap and water is very effective. In hospitals, we have requirements where we have to use antibacterial soap and water. So we're certainly not discouraging soap and water, but recognize they're going to be in full protective attire, and we want them to disinfect their gloves, which, as Dr. Ender mentioned, is something we've never done in the history of infection control. You always change your gloves. But in this case, they're having people disinfect their gloves throughout the entire process of removing each piece of protective attire so that they don't inadvertently self-inoculate, so that they don't do something that lots of people do, and I've witnessed it now. We don't know what happened in Texas. We know that unfortunately those nurses somehow infected themselves, likely during the time when they were removing their personal protective equipment, because they had it on. So the issue was it enough, or did they infect themselves when they removed it? And unless you practice this and see what it is like to be in these suits, first of all, outrageously hot, very oppressive. You could not be in that suit for maximum 2 hours. Second of all, when you take it off, it is required now from the CDC that you have a seasoned, educated observer who watches every step you do. Every step, and they read it to you. We will read, because I'm one of those trained observers, I will read step by step and watch everything you're doing in terms of putting your equipment on to make sure it's all on and it's secure and everything's covered. And then when you go to remove it, same thing. I'm going to watch and read it to you step by step by step. And then in between every step, I'm going to make sure that you don't accidentally do this. Now, I happen to have a headband, but I'm going to tell you, oh, this will probably be on the cameras. What I want to tell you is when you take off that headgear, what happens? Now, it may not happen with the gentleman, but it will definitely happen with the female. What do you think the first thing is that people want to do? Exactly. I am right by my eyes. Or people that are wearing glasses, we have now decided that we have purchased bands that will go around the back of the head, just like you do for sports. So when Pete is taking off his respirator, his glasses aren't going to come with it, and the first thing he does, I mean, it's natural instinct. So we've learned a lot of things by practicing over and over. So we will continue to use antibacterial soap, hand sanitizer with alcohol, and we will use a Clorox solution.
And I know he has one more question, and then we'll move on.
Now, here comes the zinger. The most dangerous part of all this is the first responders. Suppose that you have an Ebola patient that's no longer breathing and the heart has stopped beating. Can you deny resuscitory efforts? In other words, can you say no code blue if you come in here? When they enter, must they sign a permit? Because that's where you're going to contaminate everybody. In a code blue situation, when you start pulling out needles, endotracheal tubes, catheter sites, you know?
It's a very good ethical question, and it's certainly questions we've wrestled with. We've wrestled with how far do you go with life-saving techniques? We are all in agreement that the patients will get intubated safely, and we can also provide them dialysis safely. There's a third machine that is a heart-lung type machine called ECMO, which we have put many flu patients on. Once again, I'm going to get that flu zinger in there. It saves lives. The decision's been made by the company that manufactures it, as well as the CDC and other organizations. We will not go to that step. And that is because now you're talking about large volumes of blood outside of the human body, and very likely at that point, as Dr. Ender mentioned, their organs are failing. Even ECMO will unlikely bring them back. Now, first responder, I can tell you our job in healthcare, which is why we went in it, is to save lives. So I'd be hard-pressed to think at this moment in time that anybody wouldn't make an attempt to save a life. The unfortunate part is we won't always know, just like we don't know which patient's infected with HIV or hepatitis B or hepatitis C. We don't know all of that information when we first come upon a patient or when EMS comes upon a patient. But what they can do is make sure they have full protective attire on to put a barrier between that patient and them.
But I'm talking about when the Ebola has been diagnosed and proven to exist. Those patients stop breathing and their heart stops beating, and you say we are not going to go through this patient if the family wants it done, because they haven't signed the document.
That is a difficult ethical question that is being had by many hospitals. Here's what I have heard at some of the containment facilities that are out there, that there will be no code blue called overhead in the hospital. There will only be resuscitation by the individuals that are already in the gear that's protective for them. So, and you should have at least several individuals in that room to be able to initiate that type of therapy.
Is this rumor or is this policy?
No, well, this is not, I can't say whether it's policy or not, but these are things that have been discussed and documented as far as approaches some hospitals are taking, some of the containment.
And I know Dr. Grace has something to say, then we can move on to our next.
Sorry about that. Yes, at Emory, all patients entering the containment center do sign a no DNR, a DNR. They do not resuscitate. At Nebraska, they do the chemical resuscitation where they shoot the medications in via IV, but they do not do compressions and they do not defibrillate. And the same is what happened in Texas. The nurses at the bedside, I actually just this morning read the account of the team who was in the room at the time of the death, and it was a chemical-only resuscitation. Medications only through a central line port. So from that standpoint, it's something that, again, these people are coached and communicated with and given their options about living wills and all that kind of stuff as they're been, just like most American hospital patients are.
We have a question back here, sir.
I'd like to ask Dr. Brandon, what is the prognosis for a vaccine that could overcome the disease? Now, I know that there are two investigations, two are presently being investigated, but what is the major problem? Is it safety or efficacy, or both? Which way?
Well, the simple answer is we don't know right now. We know that in the lab, there are vaccines that looks like they probably will be, they have some evidence that they will likely, based upon lab testing, to be effective. Right now, they're doing the phase 1 trials in humans. They looked like they developed antibodies in animals, for sure. The question is, does that conduction of proteins that, called antibodies, that bind to the organisms that often protect people when they get vaccinated from viruses, will they be effective antibodies? The feeling is they probably will be based upon what we know, but those studies have to be done. And one of the concerns is, can you get reinfected with Ebola once you're infected once and you've recovered and survived? antibodies are around for a long time in survivors. The question is, can other strains of Ebola still cause infection later, or will those antibodies wane enough over time? That goes back to the whole protection from a vaccine. Sometimes it's very difficult to generate a vaccine and make a vaccine that's more effective at preventing infection than the natural infection itself. But based upon kind of the initial studies, which are very limited, they feel good enough about them to at least, they're in phase 1 studies right now, meaning it's just some patients are getting vaccinated, they look in the test tube to see if there's been a response and to see if there's side effects. Once we get past that phase of those studies, to know that they're safe and they have some evidence that they will likely be effective, then starting in January, they'll be trialed in individuals in a more large scale in Western Africa.
We're on the other side of the room, of course. Don't be shy, anybody. Other questions? So we have one over here as well. So I'll.
One other thing I will mention
Sure.
also, a good point that Terry made, there have been people that have gotten blood transfusions from individuals who have had Ebola, and at least, we call it anecdotally, there seems to have been a response to that type of intervention. Anecdotally means, yes, they survived, yes, they got the blood transfusion, we don't know if that's why they survived.
We have a question here.
Nigeria had some cases and is now declared cleared. What was done at the population level and at the hospital level to turn this possible tragedy into a success?
The specifics I can't answer, but they were much more aggressive about containment. So this was even as big, if not bigger, of a concern when you hear about it in Nigeria, in a big city environment, that this was starting. And yet there was a very aggressive approach by the government and by the hospitals and their systems that they were able to contain it. I can't answer the specifics there other than they were much more aggressive.
The other thing is, from a financial standpoint, we had 2 guest speakers come from Sierra Leone who are actually living in the hot zone. One was a minister and another one is part of a care organization that supports bringing resources there. The belief and their feedback to us was, from a financial standpoint, a resource standpoint, they were in a much better situation than the other 3 locations. So they had much better infrastructure, they had many more personal protective equipment supplies and providers, and it never got to the point where it overwhelmed them. Unfortunately, that's not the case in the other 3 areas. It has already overwhelmed them, so despite throwing resources there, the cat's, if you will, out of the bag.
Who else has questions in our audience? Ma'am?
Well, he told us about the signs posted in the hospitals now, and if they meet the criteria, people reading them anyhow, I don't know if they're in many languages, but they should go right to the receptionist instead of sitting down and waiting. It's been years since I was in an emergency area, but the receptionist then was just sitting at an open desk, and the receptionists are going to be in that position. Are they going to be really well protected?
So, good question. Recognize that our receptionists in our emergency room, as you can imagine, are exposed to lots of things because everybody and anybody comes to the emergency room with everything. As Dr. Ender mentioned early on, our anticipation is that somebody who is truly ill, vomiting, diarrhea, hemorrhaging, will be calling 911. They will very unlikely be driving themselves to the emergency room. So what we anticipate is that our receptionists are going to be their first point of contact when the individual, number one, is not excreting large amounts of body fluid, which is how you get infected. So what we are recommending they do is hand a mask to that patient and then escort them back to where one of the providers can then put on PPE and continue a more thorough evaluation and assessment. So for early evaluation and assessment, we feel that the PPE that will be provided when you actually go back meet with your provider or an RN staff, they're going to have much closer face-to-face contact. Once that patient says yes to those two questions, that patient should be immediately taken out of the waiting room and thus avoiding any other risk to them or anybody else in the waiting room.
And I would make 2 points. The first one being that anybody who has been to this environment, and especially at this point with the travel interventions where they're being coached as they arrive to take their temperatures twice a day, they're being monitored, they're calling in their results on a daily basis, and even before that, I really believe that anybody who's been to this environment, seen this illness, is not going to mess around when they start to have a fever and feel bad. They're going to be concerned that they have this. And so they're going to present in the early phase of the disease as compared to 2 to 3 or 4 days later when they are starting to have the body releases. So, from that perspective, I think that most of the time those walking in will be with fever and much less likely than of the vomiting and diarrhea that would put the others at the greatest risk. The second thing to understand is how we protect ourselves as healthcare providers, the first responders, at all times is a basic concept of time, distance, and shielding. So the less I'm exposed to something, the less chance I have of being able to inhale it or absorb it or whatever. The distance is the further away I am from the source, the less likely that it's going to make the trip to where I am and go from the reservoir, which is the person with the disease or whatever the hazard is, come through the air or through the fluids in this scenario, and then into my receptor site, which would be my mucous membranes to be able to take this. So time, distance, and then as we've talked several times, the protective equipment, which is the shielding. So we have, again, the basic concept that we use to protect ourselves against all hazards at all times is those 3 steps. And I think we all feel the same way. Go to start, put your hand towards the oven. The shorter time you're exposed to it, the less chance of a burn. If you use the mitt before you do it, you have shielding. We use time, distance, and shielding in everything we do, and we need to remember those basic concepts.
Was anyone next? Okay, one follow-up.
Well, I heard that Mr. Duncan was put on dialysis for a time. Is the dialysis machine able to be sterilized and used for other people later?
So as far as the dialysis machine is concerned, and quite frankly, any equipment that we would utilize on this particular patient, once we get a known positive, so the rapid test comes back positive, it then gets confirmed. I can only speak to the Lehigh Valley situation, but I'm sure Dr. Ender can speak. We are in the process of designating a team. So there will be a centric team that is trained in the proper personal protective equipment, a location where that patient would be housed. All visitation is restricted. We would have the capability of the family seeing and talking to their loved one without going in the room through telemedicine. And all the equipment that we utilize on that patient would be solely utilized and designated to that individual. At the end of the care for that individual, the vast majority of your equipment should be disposable. And that would include your blood pressure cuffs, your temperature monitoring, all your probes, all your catheters, anything and everything that we can, which we have currently stockpiled. All of that equipment is disposable, and yes, we've dealt with the Department of Transportation and the DEP, so we know exactly what to do and how to package it and how to ship it out. Because I'm sure you saw Emory had 16 tractor trailers full of trash. We also know how to treat the water before it would go down the sanitary sewer system. So we've crossed all those T's and dotted all those I's. In terms of the dialysate, as I mentioned to you, they found nothing in the effluent, the fluid coming off the patient. But we would take that extra precaution like we do when we dialyze an HIV patient or a hepatitis B and C patient, which are very infectious, and we Clorox that entire machine. There's also a settling time, if you will, on the room and all the equipment that's in there. We also have terminal disinfection team who would go in there and thoroughly disinfect that area. We also have an ultraviolet machine called Trudy that they actually sent to Western Africa. We've had them for a long time. it would also go in there and terminally disinfect all the equipment and anything in that area.
Who else has questions? And at other end of the room, okay, and we'll start making our way over. Yes, ma'am?
If enough money is thrown at this problem, as in the case of Bill and Melinda Gates saying that they were giving $53 million or something to stop Ebola in Africa rather than having it come here, do you have any feeling, with that regard, that if we throw enough money at it, it will stay in Africa?
So that's tough to completely predict, obviously. But the short answer is it depends how those resources are used. So it's not just money, it's people, it's intelligence, sophistication, supplies. So vaccinology, of course, we talked about the vaccine issue. So yes, if you put enough money is an important part of what needs to happen, but only a piece, because if you misuse those funds and they aren't appropriately utilized, it may not do as much as you want it to do. So our hope is that with giving the resources, giving donations, and appropriately utilizing that with information and studies, that you can keep the epidemic in Western Africa, and over time get rid of the epidemic.
We have a question up here, ma'am up front.
That's a two-part question. It involves patient zero. This past weekend, in one of our local newspapers, they quoted as saying that patient zero was a toddler in Africa. Two questions. First of all, how reliable can you take that documentation based on the fact of the conditions that are in Africa involving the whole Ebola crisis? And two, what's the value of determining patient zero?
Two questions that I can't answer very well. I can tell you I saw the same information you did about it was a 2-year-old apparently, and it was in a remote area of Guinea, and the theory is it was an exposure to fruit bats that led to this. How this information came to be, I can tell you with studies with HIV, they have done some very sophisticated analyses, and they've been able to trace back based upon some of the genetics of the virus that they find in people earlier and earlier in the epidemic, and they're able to use that genetic analysis to figure out what was early in the epidemic and what was later. So they use both, not only the clinical or epidemiologic information where you kind of trace people, they actually use science looking at the virus to help do that tracing. But the specifics of which I don't know.
So from an epidemiological standpoint, in infection control and infectious disease, our goal is to try and find the index patient for lots of diseases. For instance, not so that we can put blame, it's fact-finding, it's not fault-finding. So if you had an outbreak on a cruise ship, which you've all heard about with norovirus, it would be imperative to try and figure out where it started. Because unless you know where it started, it's very difficult to go backwards and identify the source. Now, probably very tough on a cruise ship with thousands of people, but times there's other foodborne outbreaks like hepatitis A. It's imperative for us to figure out in a restaurant that could possibly be infected with hepatitis A and all the patrons, and we've been involved in those in the Lehigh Valley more than once. I'm sure a lot of you remember the old Chi-Chi outbreak. Subsequently, that's not why the place closed, but it is closed at this point, but there have been others. It's important for us from a Department of Health standpoint, from an investigation standpoint, to find out who that sick healthcare worker, because it doesn't just appear. So in those circumstances, we have to go back and figure it out. May not be as crucial in this case, but it helps them geographically try and track where it started, where it went, And you could probably see in a pictogram, if you will, if you've ever seen any of these diagrams, you start here and you draw an arrow and an arrow and an arrow, and you can see, especially something with norovirus, which takes very little amount to spread. Basically, your hands are dirty after you went to the bathroom and you touched something else, and now 1,000 other people are sharing that same space or that same bathroom. And it spreads very rapidly. There is specific modes of transportation for Ebola, which are different, as we mentioned, than some other diseases. So all those pieces kind of fit together from a scientific standpoint to say, okay, how does it transmit it? Where did it start? Where do we have to hone our resources? Excuse me. One thing that I do want to bring to you, and it's like the best comparison I can use because I was here, and that is, in the 80s, HIV was a devastatingly horrific, scary disease. Now, the good news is we got lots of medications that keep people alive for many, many, many years, and Dr. Ender can speak to it even better than I can. And they die now from natural causes. But in the 80s, that was not the case. We had people afraid to care for those people. They were discriminated against. They couldn't get insurance. They got fired from their jobs. They weren't allowed to go to schools. People were not wanting blood transfusions. So a lot of the fear and concern we had back then, and we had thousands of people infected with HIV, completely different than Ebola, but equally as scary.
Just as an anecdote to catch on to that, my first year of training in infectious diseases, all of my patients were dying in the clinic from HIV. My second and third, by the time I finished at the end of my training, they were all living. So my hope is that we'll have a similar situation with Ebola, that we'll get enough information and have vaccines and treatments that perhaps are available, but perhaps a great comparison.
We have one question here, and then we have a special guest we'll want to introduce.
Is there only one strain of the virus, or are there other strains that have gone to these different countries?
Yeah, well, there are more than one strain. This is the Zaire strain that's currently causing this epidemic, but yeah, there have been other outbreaks that have other strains of the virus. They're similar. Yeah, none of the outbreaks have been this large. This is by far the biggest, as I mentioned in my initial talk. But they're similar in the approach. There's no good treatments other than supportive care. There's just not a lot available, and so the mortality rates have varied between the strains and also depending on the situation they had in the individual countries. But they're still very deadly potentially.
Dr. Smith, is there anything we want to add quick before we get to our other guests?
Well, I would just, I think I know what our panelists will say. If I ask them, what is the number one thing, or one and two things that we should all do here in the Lehigh Valley to stay healthy?
I'm just going to give this to Terry because she says it all the time.
Get your flu shot. Get your flu shot. Dorney Park, November 8th. Coca-Cola Park, November 9th. 9 to 3. Drive through. Stay in the warmth of your car. Bring a snack. Listen to the radio. Read the newspaper. In and out in approximately 15 minutes. You cannot beat that, and it's free. Wash your hands, and we all encourage social distancing and cough etiquette. So if you are sick, and we tell this to our healthcare workers all the time, stay home. You are not doing anything by being a martyr and coming to work at a hospital and providing care to our community when you're sick. Stay home. It's the same no matter what business you work in. The other thing is cough etiquette. We teach it to our kids in schools. Turn your head. Nobody coughs into their hands. Most people in some other countries aren't even shaking hands anymore. Doing the old fist bump. I'm not suggesting you have to do that, but communion has changed. No more of this communion chalice passed around. Everything should be individual. Same thing with restaurants. We encourage everything as much that can be individually wrapped. Keep yourself healthy, eat healthy, exercise, drink lots of fluids, and eat healthy food. Stop smoking, watch your weight.
How's that?
Just one other point about the flu. Just to reiterate the flu vaccine, last year I took care of a number of patients in the intensive care unit from the flu. These were young, relatively healthy people that were on life support for weeks and weeks, and several of them died. This is the flu. This is what can happen. So please get your flu vaccine. And as far as the fist bump, I did see a study, I don't know if you saw that showed decreased rates of transmission of bacteria with fist bump versus shaking hands. So it's a thought anyway.
Dr. Grace, anything you want to add?
For the media people, if you could be as outraged about people not taking their flu vaccine as the concern about the Ebola vaccine, again, if you look at the overall outbreak, how many deaths there have been, that's only 10% of what we'll lose a year in flu deaths.
That's a great point to add. I also know our panelists will be with us later on after the program for some informal questions, I'm sure, from our audience. As we're kind of beginning to start to close this down, when you work at a public science center, surprises happen almost every day, and that's great. And when you put together a public fact forum, sometimes you get greater surprises. So we have a very special member of our audience today who we want to have a moment with. His name's Ron Nelson. He is a retired teacher in Allentown, and we also have one other person here who both Ron and the other person we have here who are former Peace Corps volunteers who have served in West Africa. Ron was actually here there as late as July, I believe, so that means he's safe. But we wanted to have a moment for him to kind of share a few of his pieces. We also have another member of our audience who should like to come up and join us as well.
Good evening, everyone. Just a couple things. Dr. Ender, Ms. Berger, you covered some of the things that I was going to mention concerning the cultural aspect of Africa, which is really causing more and more of the problems with Liberia. A couple things. Liberia is the fourth poorest country in the world. So for this reason, even though Dr. Ender talked about it giving money, make sure it's going to the right people. Because so much of the money, due to bribes and corruption in western part of Africa, the money goes into the pocket of the politicians and this sort, not necessarily going for the people who really need it. The handshake, you just mentioned, I'm just pulling a couple of notes because you covered some of the things I was going to say. In Africa, those of you that are old enough to remember the black BAP handshakes, this is what you find a lot of in Africa. And most of them now are going to the fist bump or no handshake at all for this very reason. They're not doing it at all. Ebola, I don't know if you know about it, but the first was discovered in 1976, and it was in Africa, and they were trying to figure out what to call this thing. And they ended up by using the name of the river that ran through the village because they didn't want to get the stigmatism of Nutropoli virus, Allentown virus, or whatever it might be. So it turned out that instead what they did was they named it after the river that was there in Africa. And the biggest thing, and I know we've been sitting here for a while, but the one little thing I'll just try to mention on is the culture. And again, Ms. Bender, you did cover this, that over there, 70% of the children are born out of wedlock. There's not really a family unit like we have here. So what happens is that people take care of little kids within the village. There's not necessarily a family unit per se. So when someone gets sick, the family unit of aunts, uncles, sisters, brothers, and this sort of thing get together and take care of the people. What happens is, and you've heard the details, people get sick, the body fluids, the diarrhea and all this. So then we start trying to help the people because the hospitals are not going to take them. There are no doctors or very few doctors. They don't have the facilities and this sort. So what happens is that these people simply get sicker and sicker, pass it on. I had heard the rumor that the zero person was a 2-year-old person. They think that child died. The sister, a mother, and aunt was taking care of it. And I may be corrected on this. I'm not a medical person. I don't have access to a lot of the details. But my understanding is that all three of them then went to different villages and this house, and they started spreading out and continued on. What happens though then is that when they are taking care of family members, they're getting sick, they're bathing the body because this is the proper way. This is one of the problems also in Africa, culture. If you are told you don't take care of your family members, you don't take care of your elders, shame on you. So this is where Dr. Ellen Sharif Johnson, who's the first black female president in an African country, had told the people bodies must be cremated. They won't do this because now you're not giving the proper respect to your elders. So the people then get sick, they're bathing them, they're wrapping them in cloth, they have a little cut on their finger, they pick up the virus. That's all I have to say. I'm going to be around here too if anyone wants to talk to me. I understand another Peace Corps volunteer.
Right, we also have another Peace Corps volunteer here. Her name is Audrey Dow from Allentown. She also would like to add something, and then we will wrap up.
The main thing I'd like to add is I was a Peace Corps volunteer 50 years ago, and I am horrified 50 years later that the same problems, the same inability to get health care is still going on. I don't know why. I mean, we tried our best, and I don't know if it's money or countries that don't think Africa is worth, maybe drug companies don't feel it's worth the time and the money to get something for a country that nobody cares about. That's about all I have to say. It's just, it shouldn't be happening 50 years later. The same thing, the same children are still dying, people are still getting ill from any strange diseases, and yet we can go in and the Marines can build hospitals and they can, I don't know where they're going to get the water and stuff from or whatever they need, but that's it.
Thank you. All right, and thank you very much again to our panelists. And with that, we'll conclude the fact forum. Thank you all for attending, and have a good evening.